Good morning and good afternoon and good day wherever you are. This is a talk on the history of shoulder reverses, its indication in biomechanics. I'm Dr. Shah, I'm one of the orthopedic consultants in the Mental Hospital. So before I tell you about shoulder reverses, I just want to make a statement that is, there is a question that everybody asks me, is there a role for hemiprosthesis in trauma? And the short answer is no. Unless you're such a great surgeon that you can replace the tuberosities to such a position where they don't fail and the cuff works. There is a role for hemi in non-trauma cases when you're very young, and you can have an interposition arthroplasty with a pyrocarbon hemi, but in trauma, realistically, very little role of hemi. And that the evidence suggests that the role of hemi in trauma is following, the role in arthritis is following, and the role in other indication, however rare it is still there. So the main topic for today is history to start with, and unlike hip procedures, the shoulder biomechanics came later. The arthroplasty started first. In hips, biomechanics came first, and then the arthroplasty bit. Okay, and most of the time these were performed for tubercular infections in shoulders, where there was not much available at the time, and rubber was the mainstay of use. Ivory came in next, and the first implanted procedure was done by Emile Lepine in France, where his dentist made him an implant. Although the first evidence that was published was from Stockhausen Gluck, which made his implant from ivory, was saying that he made an ivory implant for nearly everything. So this is Julius Emile Lepine in 1893. He did his first shoulder replacement. This was for a tuberculous patient. And as you can see, it is the beginning of the reverse. He understood the fact that there was no cuff. So he made a glenosphere kind of implant from rubber hardened paraffin, put the rubber hardened implant onto the humerus, and attached that to the scapula with a titanium wire by loops. And this was actually 26 years before the first hip replacement, so quite a long time away. There are still evidence in X-ray of the implant in some of the anatomical museums. As mentioned earlier, Gluck then made ivory implants, but he made ivory implants for nearly everything in the body, including the shoulder. And that was carved from ivory to put in, but it didn't really work. So the first person who started really looking into the reverse was Neer, because in 1940 he was putting hemis that he had anatomically looked at various cadavers and designed them and eventually perfected them. He didn't write them until the 70s. Before he published them, he did a lot of changes into Mark 1, 2, and 3. Similarly, he realized that when he had no cuff, his hemis didn't work, so he started reversing the technique by putting a mechanical stop from the humerus to go up, and he used a big head, cemented it, and made a shape for it onto the humeral side. That didn't work, so he changed to Mark 2, where he made a smaller head, so the center of rotation was a bit away, and got some movements. But again, the humeral bit failed, as did the scapular bit, because of the pelvic fixation. Reeves looked into it in 1972, and he made a constrained prosthesis with poly and metal that was sort of closed together so it wouldn't dislocate. The humeral side had the cup, and the glenoid side had the ball, but the surgeons found it very difficult to hold this into the glenoid, and therefore they failed, and cementing technique was very poor. So Gerard and Lenlong, that's what it is, Lenelong, in 1972 designed their prosthesis on a similar basis, but instead of cementing the whole of it, they put some screws into it to allow it to bond onto the scapula, and that was the beginning of the modern uncemented implants. It looks like a modern uncemented implant with a humerus receiving the glenosphere, but the glenosphere is small and the movements were not very good. And there was a lot of rocking onto the scapular side. So to stop it, Colbell in 1973 designed a prosthesis, but used an extra bit of metal weight that actually went on top of the scapula to stop it from rocking. It didn't work. Castle then started a screw-in glenoid and an implant that went into the stem. There are some remnants that we can still see of this particular implant, and the Copeland resurfacing stemless is based on this particular model, I think, because it has a screwed in glenosphere and a small receptacle for the humerus. To note here is the vertical part of it, which is an unstable construct, and there's a lot of pressures going around it, and the stress on it is a bit too much. So that eventually changed into different parts, different types. Bailey realized that the glenoid was a problem, so he put a coated hydroxyapatite coated to allow bone ingrowth, and this is a picture that I found one of the archives, that this is 15 years following surgery, and apparently it was working, although you can see there's a lot of osteolysis in here. Franklin also worked with the similar prosthesis. He made the head bigger, and he made a fin that actually went into the scapula for better stability. The first hip-looking like implant came from Liverpool by the Bedo Alloy Group, and in 1975 we had a scapular part and the humeral part, which was cemented. Unfortunately, that also didn't work for a long time. Boyle and Pappas in 1978 made a constrained implant, which did work in the sense that there were 7 implants inserted and none of them failed because of the implant. Don't know what the long-term outcome for this was. Christina, taking on further, made a trispherical design, which like a ball in a socket, ball in the ball, like a bipolar design, with screwing in the shell on top of it to allow it for stability. Unfortunately, that didn't work. So if you look at the history and evidence of reverse shoulder arthroplasty, you can see that most failed because of the device-related implants. Some were aseptic, however, mostly it was device-related. The only one that I did tell you was the buccal implant, which inserted 6 and it didn't fail at all. However, I'm not sure what happened to the long-term outcome for this. All the trispherical constrained bipolar ones failed because of implant-related complication. So the first real adventure into reverse prosthesis that actually worked with a trumpet prosthesis, which looked like a trumpet, a French for a trump, for a musical instrument, trumpet. And Grimond decided that the deltoid for the first time was important and actually allowed to lateralize and distalize the implant. He actually used is an implant that in some way revolutionized the reverses and started to work. He did a polyethylene humeral stem. He had a cemented glenosphere that medialized the center of rotation to distalize the humerus. And as I mentioned earlier, this was the first time that the deltoid was considered as an important function. After Grimond had started his implants, there was a paradigm shift, which meant that anatomy was important, but to have better results, we have to change natural anatomy. And the reason is easily understandable when you talk about biomechanics. Instead of mimic nature, we need to improve nature. Saying that, Grimond first came up with a hemi kind of implant, which was screwed into the humeral stem for fractures with a varus head to stop the forces to allow compression rather than tension onto the tuberosity. He eventually perfected his implant, which is the first delta reverse, which was launched by Dupuy, where the component was medialized, it was modularity, and the central screw for the base plate was compulsory. The current process in arthroplasty is under construction, although we have nearly perfected it. We need to do more work on it. It has to be a cementless option where the variable angles and eccentricity should be part of the implant. Okay, and as you go back to biomechanics, which is where the implant is taking shape, the implant has a center of rotation, and as a supraspinatus just doesn't work, it migrates superiorly, and because it migrates superiorly, it's not congruent anymore, and therefore it doesn't work. So the easiest thing would be to put the ball back into the socket mechanically, either by repairing the cuff or by putting a balloon in it or by metallic implant. And that's when function comes in and the deltoid comes into play and allows the shoulder to move better. Okay, and biomechanically, by distalizing and lateralizing it, we increase the lever and therefore forces to allow the shoulder to become greater and easier for abducting the arm, and it is increased and the torque force is much better. So simply, cuff, no cuff, mechanically cuff distended, and which is the basic principle of the reverse total shoulder. Okay, and how does it work? It works by either medialization or lateralization of the center of rotation, by distalization and make it semi-constrained. So when we medialize it, we convert the shear forces to compression, and in that way, the base plate glenoid interfaces are compressive rather than tension. By distalizing it, we tension the deltoid, and by making it semi-constrained, we overcome the deficient cuff. Although saying that, all we have to do is put it back into the socket and the deltoid will make it work. So this is medializing. The center of rotation is in that direction because it's out there. By medializing the center of rotation, it is now no longer tension but compression, and allows the base plate to have little issues. The benefit of it is it causes the base plate to move better. It causes the joint to move better. Okay. By distalizing it, we stretch the deltoid. By doing the deltoid stretching, it causes wrapping, which is called the deltoid wrap, which makes it more efficient. The lever arm becomes better, and the moment arm makes good function at the shoulder joint. Just going back to basics, the first shoulder reverse was the Grumman type, which actually medialized the center of rotation. And it was good, the function was there, but as you can see from the original implant, there is a bit of notching, and that's what was the main problem was. So the easy option was, if it is notching, let's move everything lateral. By doing that, the deltoid stretched itself, and therefore the function was there, but because of the function, there was a rocking horse phenomena, which made the base plate loose. So although the function was there, the glenoid base plate started to fail. And therefore, that was another option to look at in a different way. However, the good thing that came out of it was subcap could not be repaired, and therefore, as subcaps could not be repaired, they left it alone. And by leaving it alone, it made no difference. So in the future implants, if you can repair the deltoid, great. If you repair the subcap, it's good. If you can't, then it's not the end of the world. So current implants now have a center of rotation where it should be, or around the place where it should be, and the humerus is lateralized. By doing that, they distalize and lateralize the deltoid, and you have a deltoid wrap, and the function is far more efficient. Lateralization, which is what we are doing at the moment, causes improved rotation, and it improves the deltoid contour, and there is less notching. Humeral cut is also important. The initial Grumman and whatever was about 155 degrees, but now by doing 135, it decreases the chance of lateralization, the chance of notching, and also gives some stability. The more vertical it is, the less the stability is, but 135 seems to be the compromise. The other thing is we need to understand what the inlay and onlay system is. I will come to it in a minute, but the deltoid tensioning is important because the deltoid is in a position where it is already fired up and it's pre-tensioned and ready to go and work, and therefore no energy is lost in tensioning the deltoid. The other thing is if we do initially, the deltoid has to fire and get to maximum tension and make it work. And now, however, if we tension it too much, the other compromise is that the acromion fractures because of stress, and we have stress fractured acromion. So this has to be very balanced. Stability is an issue, and initially the radius of the glenosphere and the depth was looked into, and it turned out that the deeper it is, the more stable it is, and the bigger the head is, where it is contained, and it will give stability. The original Near design had a big head and a small base plate, and that was causing a problem. Okay, so the other thing we were talking about is rocking horse phenomena. If you put an implant which is congruent and in a good position, but the screws are straight, Then by moving with the shoulder, you get what we call a rocking horse phenomena, and it loosens. That was compromised, or that was changed into screws that are going at an angle, which stop the rocking horse phenomena, loosening on the screws. Okay, and as I mentioned earlier, 135 is the optimum position for it to be stable and get function. The more horizontal it is, the more stable it is, however, less function and notching. So initial Gremont was about 150. Nowadays, the modern implants are 135 and 13 and similar in inclination. To understand the inlay and onlay system, when you have an inlay system, the deltoid is tensioned by the tuberosity, because that's where all the lateralization is. However, if you do an onlay system, which means that the implant is outside the tuberosity, the deltoid is not as much tension, and therefore we don't have certain functions. So it's important to know what is the lateral shoulder angle and the distal shoulder angle. In the Lima, which I use, it works with the lateral shoulder angle and distal shoulder angle, which is about okay. The other one that comes nearer to this particular implant is the Tournier reverse, and it does have a better distalization but less lateralization. And if you look at the biomechanics of it, apart from abduction, it doesn't really matter, but that's what it is, and that's what the difference between the inlay and the onlay system is. Okay, and we understand very, very clearly that when the distal shoulder angle, which is the distalization, between 40 to 65, we have good abduction, and external rotation was highest when the lateral shoulder angle was between 70 to 90. Okay, the constant Muller score did not change with the type of implant that was put in. Okay, so biomechanically, a good glenoid position, humeral position approach, neck shaft angle, metaglenoid eccentricity, metaglenoid inclination, bearing surface, and humeral version are important factors for a surgeon to decide which implant he wants to use and what is the long-term outcome from it. Okay, according to the joint registry, the commonest one that everybody looks at is the Australian, and it looks at that the best option for a shoulder replacement will be 135 inclination with a medial glenoid, but lateralized humerus. Our center of rotation is normal, and we've lateralized the humerus. The glenosphere should be 40, it should be uncemented. If it's a 60 and a female and we use an inlay system, then the outcomes are very good. That in word really describes the Lima SMR. Okay, so this is a patient of mine. He's got a Hamada 3, no arthritis, but no cuff, and it was the right age, so we did a reverse shoulder for him. Now, looking at this particular picture, you can see that the biomechanics was restored, and you can see that the tuberosity is going back to where it should be. And I saw this the first time and I was amazed, but it is now a common phenomenon. Most of my patients end up with the tuberosity going back again. This is a patient who is a year down the line, and he's not perfect, but he has amazing movements in his right shoulder. This was the x-rays I've just shown you. So right age, right implant can have good outcomes, okay? I hope this helped for you to understand the basics in biomechanics and allowing you to choose which implant you want to use. Hopefully that should clear some questions in your